See, you don't have any. It is not one. Just 1 minute. See, all the
Yes.
word letters are all in the black background. I don't know
Okay.
how he did it. He should not. Does he not check and see? I am sitting and redoing all the things.
Okay. Background.
Yeah, you
Yes,
will
sir.
yourself see in the background. Nothing is there.
Mhm.
See, you should never give this that all that figures has got that background. It is wrong actually. Okay, start.
Yes, sir. You can start, sir.
So live streamed sharing.
It's a, yes, sir. It's a live streaming.
You can see the slides.
Yes, sir, we can see.
Yes, sir.
Okay.
You can see, sir.
Now you can start your introduction. We will go ahead with that meeting. You can see me.
Yes, yes, sir.
You can see me. Huh?
Yes, sir. You can see, and voice is also clear. No issue.
Okay, fine.
You can start present, sir. No issue.
Okay. Today we are going to discuss about the bone turnover markers in osteoporosis, its role in the diagnosis and treatment guidance. So we will be discussing this in this following pattern: the bone turnover morphology, pre-analytical variants, diagnostic and monitoring, treatment guidelines, and clinical cases and algorithms. So when we are talking about the bone turnover morphology, there is something like a formation marker and a resorption marker. If you look at the formation marker, it is derived from the osteoblasts, reflecting the bone synthesis. And bone which is resolved, there is a collagen degradation. They reflect the osteoclastic activity. Under physiological conditions, both formation and resorption are tightly coupled. If the resorption is more and the formation is not able to keep up, then you will have osteoporosis. It can be age related or it can be due to a disease where there is parathyroid excess, and because of hyperparathyroidism, we can have it. So, the bone turnover, bone modeling is a continuous cycle. The markers are biochemical products of the osteoblasts, that is for the formation, and of the osteoclast, that is for the resorption. Now, the marker, the serum, is for the formation, is the P1NP, the collagen type 1, bone specific alkaline phosphatase, and the osteocalcin. They are forming the matrix. Then the bone resorption markers, that is the CTX, the NTX, the telopeptide of collagen type 1, and NTX is in the urine, CTS is from the serum, the trap, dipyridine phosphoryl links in the urine. So those which are in the urine are not much used because of the high coefficient of variation. And what is very sensitive is the CTX, which is a marker of bone resorption. So the bone formation markers are the P1NP, bone specific alkaline phosphatase, and the osteocalcin. Now, the International Osteoporosis Federation and International Society of Clinical Densitometry has got their references. The P1NP, the formation is the standard reference method. CTX is the resorption standard. So P1NP, it is least affected by the food intake. CTX is the most sensitive to resorption or anti-resorptive therapy. Both show large treatment effects and size. So the rationale is high analytical sensitivity, lowest pre-analytical variability, and broad guideline validation. So the International Osteoporosis Federation has given a consensus statement in 2017 and has been reaffirmed in 2022 that the P1NP and CTX can be designated as reference for bone turner markers for use in clinical trials. While the P1NP is a formation marker, CTX is a resorption marker. So the critical foundation is up to 40 to 60% of the bone turner marker availability is pre-analytical. Standardization is essential before clinical interpretation. So the circadian rhythm, the CTX peaks between 5 and 8 hours in the morning. So draw the blood after 8 to 10 hours overnight fast between 5 to 8. After 8, try to cut it off. So the CTX reduces by roughly 20% postprandially. So after food, the values will be 20% less than what you are taking. P1NP is less affected, but fasting is still recommended. So when you are drawing blood for CTX, take it immediately for the P1NP also. Seasonal variations are also there. It is elevated in winter or when there is low vitamin D. So correct the vitamin D before interpretation. So when you are treating a patient with osteoporosis, when he has got low vitamin D, treat that first and then do the marker and then go ahead. Physical activity, strenuous activity elevates the BTM, bone turnover markers, by roughly for 24 to 48 hours and are advised to rest prior sampling. This is very important for people who are taking strenuous physical activity or bodybuilders who have been on major physical fitness program. So pre-analytical confounders are age. Both markers are elevated. Menopause less than 5 years. There is increase in CTX. There is a turnover marker. In CKD, the osteocalcin and NTX falsely elevated. We don't do this. Hepatic diseases, the bone specific alkaline phosphatase or the alkaline phosphatase are unreliable. Immobilization, resorption is more than formation. Recent fractures, you had a fracture, road traffic accident, or a surgery of the bone, like a knee replacement or hip replacement, do the markers, it will be very high for 1 to 2 months. Vitamin D deficiency is PTH driven markers of elevation. So when you are doing these markers, they will have to be very careful. The glucocorticoids suppress the formation and resorption later. Hormone therapy decreases the CTX. Proton pump inhibitors modulator reduce. Thiazide diuretics reduce. Anticonvulsants elevate bone specific alkaline phosphatase. There's another thing like least significant change. It defines the minimum change in bone turnover marker that exceeds the measurement noise, essential before attributing the changes because of therapy. So, if you want to say that bone turnover marker, that is a P1NP and the CTX, the resorption and the formation markers. If you have changes below the least significant changes or within biological and analytical noise, do not alter the management based on the LCS shifts. So, the coefficient of variation is 8 to 12%, which is permitted, and the least significant change should be more than 22%. So you should have a marker typically with these values above so that to say that patient has got an improvement in therapy. So use the same laboratory and the same assay platform when for serial measurements. Don't keep changing it from laboratory to laboratory. So the population references what you have is premenopausal P1 and P is 19 to 84. CTX is about 100 to 600. Postmenopausal women, the resorption is more, so it is high. Men and women, it's up to 50 years and beyond. The range slightly goes up. And in Indian postmenopausal women, India specific norma are limited, and extrapolation from Caucasian nations have been used for this with caution. So we as it is, we don't have a normal value from in our population for that. So bone tone markers in diagnosis of fracture, risk and disease activity. They don't diagnose osteoporosis. If you want to diagnose osteoporosis, DEXA is the gold standard. Elevated bone markers, independent of fracture risk, or beyond BMD. So if you have a bone turnover marker which is high in the absence of a fracture, then it becomes very important. So there is most informative when the BMD is in the borderline. Borderline, what it means, minus 1.5 to 2.5, they can tip the treatment decisions. So International Osteoporosis Federation says bone turnover markers add up to 4 to 10% improvement in fracture determination when added to FRAX. So when to measure turnover markers? It is appropriate to use and exclude secondary causes of elevated turnovers, example, pages and malignancy. Assess treatment naive high turnover state prior to therapy, borderline BMD with high clinical fracture risk, monitor response to therapy, primary clinical utility. So when you're using osteoporosis treatment and you find a borderline BMD which is find out to be with high clinical fracture risk, whether it is improving or not, primarily is clinical utility is here. Treatment naive poor high turnover states prior to therapy. Exclude the secondary causes of high bone turnover, example, pages and malignancy. Not recommended for screening or population based diagnosis. So you can't make a survey, say like you do a survey of vitamin D, select that, and this you can't give it. Sole basis for initiating or withholding therapy. Replacing DEXA in fracture risk assessment, cross platform serial comparisons. So the interpretation algorithm is you have an assay reference range, compare the results to the assay specific reference intervals, assess the magnitude of the change, evaluate the changes versus the least significant change. Pre-analytical variations, that is a fasting sample, no recent fracture or vitamin D treatment. Integrate the clinical context, combine with BMD, FRAX, fracture risk and comorbidity. So the bone turnover markers in monitoring anti-resorptive therapy primarily a value in early confirmation of treatment response within 3 to 6 months. When DEXA is not seen, DEXA changes will happen only after 12 to 18 months. Before that, if you want to see, then the bone turnover markers are very important. Bisphosphonates, the expected bone turnover marker response is the CTX falls within 3 months of initiating oral bisphosphonates. P1 and P declines by 50% by 6 months. Formation suppression follows resorption within 3 months lag. So in IV zoledronate, CTX nadir at third month, sustained suppression for 12 months. Failure to suppress CTX by more than 33% in the third month, suspect non-adherence or malabsorption or secondary causes. So you have to monitor CTX at the third month as resorption check, P1 and P at the 6th month for coupling and formation. When you are using denosumab, a rank ligand, the profound CTX suppression occurs within the first month greater than the bisphosphonates. The BTM burnt turnover marker suppression is reversible levels rebound within 6 months of discontinuation. Rebound resorption takes a spike. So when you're stopping denosumab, you want to see whether it is going for a rebound level. So you look at the markers at the end of 6 months. So rebound resorption spike, multiple vertebral fractures if denosumab stopped without transition therapy. So if you are stopping a denosumab therapy, you have to transit it either to a newer therapy of other anti-resorptive or you take it over with the bone formation anabolic levels. If you don't do it, then the chances of rebound fractures can occur. They're critical in monitoring adherence and detect missed injections before fracture. So discontinuation alert, raising CTX after denosumab is mandatory transition for bisphosphonates. So the rebound occurs at 30th month discontinuation without transition. So it's very important. Now, denosumab discontinuation, how does it help? So denosumab is stopped, rebound bone resorption, vertebral fractures. So the transition to allogeneic within 6 months of last denosumab dose, monitor the CTX, the resorption markers at the third and 6 month post injection. So it tells you where you stand. Now in anabolic therapy, how do you monitor? The agents produce distinctive BMT signature, early market and formation is increased, preceding or exceeding resorption, the mechanistic of the opposite of anti-resorptive therapy. Here you are giving an anabolic therapy. When you are giving an anabolic therapy, there is an increase in the formation, preceding or exceeding the resorption. So it is the opposite of anti-resorptive therapy. In anti-resorptive therapy, you suppress resorption, whereas in an anabolic therapy, you increase the formation. So the formation markers will be more. So when you give teriparatide, the P1 and P level rises within first 3 months, which is a robust signal. Then the CTX raises later, the anabolic window in the first 3 months. So the early P1 and P rise more than 10 micrograms predicts subsequent BMD gain. Absence of P1 and P rise at the third month questions the adherence. So the patient is not adhering to therapy. So the minimum P1 and P response typically at that 6 month plateaus thereafter. So that is very important. So you should have a 25% increase PM and P at the end of 3 months, which is a positive treatment and a response indicator. So if you don't find an increase in the P1P, but when you're treating with the bisphosphonate, you look at the CTX suppression. That is very important because it is an anti-resorptive. Albuperitide is a PTH1 resorptive peptide analog. The BMT signatures will be totally different. You find the peak at the third month, whereas it plateaus for 6 weeks at 6 months at teriparatide. Here, CTX rise is moderate and delayed. Here, it will be low and the selective anabolic window. Monitoring both in 3 to 6 months. Post therapy bone turner markers fall. Rapid and transition is needed in both the situations. So, albuperitide has more favorable anabolic catabolic ratio reflected in lower CTX rise relative to P1 and P compared to teriparatide. Romosozumab is a dual bone turner marker signature. It's an anti-sclerostin antibody, stimulates increased formation and decreases the resorption. So the P1P rises within by 80% in the first month, and CTX fall by 60% in the first month, opposite to teriparatide. This uncoupling is unique and transient burn turnover markers effects diminish by 9 to 12 months. So in the frame turnover trial, you have the turnover markers change, predict bone BMD gains and fracture reduction is been shown. So you have to monitor P1 and P CTX at the first month and 6 months to confirm dual response and assess the waning effect of the drug. So now, this is a comparative bone turnover markers across agents. This is the anti-resorptives here on the top. Alendronate, risedronate are bisphosphonates. Denosumab is a ligand. So the P1 comes down. The CTX also comes down. You monitor third month or one first to third month. Here, teriparatide is an anabolic agent. Anabolic PTH is albuperitide is PTH related peptide. Romosozumab is a sclerotin agonist, which has got dual action. So here you find the markers of formation rise immediately at the end of third and 6 month, and CTX is also rises because some amount of resorption is required for the bone to form. So sequential therapy, anabolic to anti-resorptic. After teriparatide, romosozumab completion, BMD gains are lost within 12 to 18 months without consolidation. So immediate bisphosphonates or denosumab after anabolic leads to increased bone turnover form to anti-resorptive age. So you have to give bisphosphonates after stopping an anabolic agent. P1NP and CTX monitoring at 3 to 6 months post-transition confirms successful coupling suppression. So when you're doing the reverse from anti-resorptive to anabolic, prior bisphosphonates blunts anabolic bone turnover markers, that is a residual skeletal effect. Zoledronate pre-treatment, P1NP rises to teriparatide, delayed by 6 to 12 months. Denosumab to teriparatide, paradoxical resorption surge which occurs. So the IOF guidelines 2022 says from antiresorptive anabolic sequence is suboptimal. Prefer anabolic fast strategy in very high risk patient. So in PTM and treatment selection, anabolic versus antiresorptive, how does it help you to treat? The preterm bone turnover marker status informs which agent class is appropriate. High turnover states responds differently from low turnover osteoporosis. So the bone turnover marker guide selection framework. When you have a high turnover, CTX upper above normal and P1 and P elevated, prefer antiresorptive first. Then is a bisphosphonate. If the turnover is low, CTX is below, P1 and P is low, consider anabolic therapy first, teriparatide and rozumabad later. Very high fracture risk rate, where the BMT is less than minus 2.5, prefer an anabolic agent. Post-anabolic monitoring, transition to antiresorptive mandatory to gain for the maintenance of the gain. High turnover osteoporosis, antiresorptive priority, CTX indicators of high turnover. So, clinical indicators of high turnover, CTX in the upper limit of reference range, P1 and P disproportionately elevated, early menopause less than 5 years, secondary hyperparathyroidism, that is vitamin D deficiency CKD, glucocorticoid induced osteoporosis, which is in the acute phase. Management implications, antiresorptive therapy, denosumab, zoledronate, most effective. Addresses underlying causes first. Correct vitamin D, CKD, and MBD. Bone turnover markers, measurement after 3 months, confirm the suppression. If CTX fails to suppress, exclude secondary causes, myeloma and metastasis. Low turnover osteoporosis, anabolic therapy is a priority. CTX at or below low limit, P1NP suppressed to normal, common in prolonged bisphosphonate therapy, glucocorticoid or adenoic bone diseases, or atypical fracture of humors are associated with severely suppressed bone turnover markers. Anabolic indications, teriparatide preferred, stimulates osteoblastogenesis, reverses suppressed turnover. Romosozumab is effective in low turnover states. Monitor P1 and P rise at least 3 months to confirm anabolic response. Blunted P1 and P response to heavy pre-treated patients without washout period. So bone turnover markers are scheduled by agents. Pre-turnover, pre-treatment P1 and PCTX at the end of first and 3 months, then secondary check at 6 months, then 12 months, and
Any brand?
biannually you
Yes.
start
Any
assessing.
brand good? Newly added. Only Gargle.
Guideline recommendations. All the associations, the International Osteoporosis Association, American Association of Clinical Endocrinology, Endocrine Society, Indian guidelines, they follow Indian Osteoporosis, International Osteoporosis Federation. The bone turnover markers are recommended with caution where there is local normative data is lacking. We don't have a normative data, but it always helps you with the reference range is given in the baseline. Before starting therapy, you do it and then later you follow, then it is useful. Challenges, limited normative data or P1NP and CTX in Indian population. High prevalence of vitamin D, more than 80% in some cohorts. Confounders with baseline. Dietary calcium and phytate rich may affect bone turnover markers. Assay availability is by Roche and IDS system. ICMR and IOF data advocate caution with Caucasian reference ranges. Practical guidance for India, correct vitamin D deficiency before measuring bone turnover markers. Use the same laboratory for serial measurement. Apply manufacturer's local validation range where available. They're particularly useful for adherence monitoring in a resource limited settings with infrequent DEXA assessment. You should complement, not replace the radiological picture. So, clinical cases, you have postmenopausal osteoporosis woman, 64 years with a T score of 2.8 minus in the spine and minus 2.4 at the hip, started on alendronate, Returns the CTX, which is very high range, essentially unchanged. Pre-range to post-range, it is pre-range is pre-treatment is 870, post-treatment is there. P1NP is minimal decline. So expected CTH should fall by more than 50% to 400. So failure to suppress is non-adherence unless proven otherwise. So review the tablet. Ask them whether it's sitting upright, full glass water, 30 minutes fast, exclude malabsorption. If adherent, confirm, but no in response, switch to IV zoledronate and reassess after 3 months. Similar scenario of denosumab, 4 to 6 months. Last injection 9 months ago, patient forgot to take. CTX has gone up compared to pre-treatment level from 680 to 140, 1420. Now new fracture at the spine. Interpretation, CTX more than twice the pre-treatment baseline. Rebound reabsorption. ASBMR mandates immediate anti-resorptive therapy. Give alendronate 5 milligram IV as a bolus. Do not restart denosumab without transition plan. Monitor the CTX again. Educate the patient. Administer zoledronate. Monitor CTX at third month. Educate the patient. Denosumab holidays are dangerous. Consider transiting to bisphosphonates in long term. Scenario number 3. 68-year-old lady with a T-score spine minus 3.4 minus 5 for with 5 years and alendronate started teriparatide. P1NP at 3 months baseline is 72, 78. Rise is only 8%. CTX is unchanged. Blunted P1NP response after prior bisphosphonate. Expected delayed response of 6 to 12 months. Continue teriparatide. Remeasure P1NP at 6 months. If still no response at 6 months, consider switch to romosozumab, less impaired by prior bisphosphonate therapy. Same thing about case 4. 65-year-old 8-year female with T-score of minus 3.7 started on romosozumab 210 milligrams for a monthly. At the end of 1 month, P1P is higher. There is a rise by 92%. So CTX comes down. So ideal dual bone turnover marker response confirmed. P1P rise more than 60% and CTX more than 1 month. This is an expected pharmacodynamic signature. Continue the dosing for 12-month course. Reassure for make both markers at 6th month attenuated. At 12th month completion, transition immediately to zoledronic acid denosumab. Post transition, bone turnover markers to be checked at third month to confirm anti-resorptive therapy. Now, overall, over suppression of bone turnover markers when to worry. Atypical fracture of humors, CTX less than 100 on prolonged bisphosphonate therapy. Signal to reassess. Consider bisphosphonate holiday. P1 and PCTX monitoring every 12 months. Osteonecrosis of the jaw. Bone turnover markers do not predict osteonecrosis. And the cutoff of less than 150 proposed by some dental guidelines not endorsed by our endocrine society. Do not use bone turnover markers as a sole determinant of osteonecrosis. Aerodynamic bone diseases accumulate due to reduced renal clearance, falsely elevated CKD in CKD stage 4 and 5. TRAP 5B is preferred resorption markers, not renally cleared. Bone biopsy remains the gold standard. In special population, when the CKD EGFR is less than 30, use TRAP 5 over CTX and P1NP. Osteocalcin is unreliable. P1NP is still usable with caution. Postmenopausal women, bone turnover markers vary with menstrual cycles, lower clinical utility for treatment monitoring. Secondary causes dominate the etiology. Men with osteoporosis, CTS is higher in hypogonadal men. P1NP reference ranges differ from women, so monitoring principles are identical. Oncology in bone metastasis, markedly elevated bone turnover markers suggest bone metastasis or pages. NTX is used in oncology trials. Dramatically elevated CTX always excludes malignancy. So the interpretation is nodal, pre-analytical, verified, yes, continue, no repeat sample. Compared to reference range at the node 2, elevated sample. Node 3 treatment naive, yes, assess fracture risk, no assess, no assessed response versus baseline. Then yes, confirm, no repeat sample. Exceeds the least significant square, yes, confirm the efficacy, no. Investigate adherence. Note 5, integrate with the DEXA and FRAX and clinical symptoms for final management. So sampling protocol, timing 8 to 10, fasting overnight, posture seated, not exercise, sample type, serum fasting, centrifuge delay less than 2 hours from drawn, storage, minus 80 degrees for batch analysis, recent fracture, postpone 3 months, post fracture, seasonal, not season corrected for vitamin D. Key takeaway, PDO, NP, and CTX are the reference range BTM standards. Always use fasting morning sample. 60% of the bone turnover manufacture is variability in pre-analytical. So verify before interpreting. Bone turnover markers are monitoring tools. They are not diagnostic tools. DEXA and FRAX remain the cornerstone. Each treatment class has a predictive turnover signature and use expected response pattern to confirm efficacy and detect non-adherence. Denisumab discontinuation requires mandatory BTM guided transition. Raising in CTX after being burnt turnover marker is an emergency anti-resorptive rescue. Thank you.
Thank you very much, sir.
Yes.
So thank you for your valuable time and giving this one, sir. We deliver the topics for this, and in future also
There
with
are a
the
lot of
same. I
questions
want.
in. Tell me.
Sir, in chat
So in
box, we have
future,
shared few questions.
Yeah, I'm addressing one by one.
Yes, sir. Yes, sir.
Do you use serum or urine markers? What makes one reliable in day-to-day practice? Use only serum markers. What common pre-analytical errors lead to misleading BTM values, which we have discussed? Take it in the fasting state before 8 o'clock. Look at the least significant variations. Do you use burnt tower markers for initial assessment or mainly for therapy monitoring? It is not used for mainly a risk assessment. It is used only for monitoring because in India, vitamin D deficiency is rampant, so you don't have normal values. After stopping denosumab, can BTM help predict rebound bone loss? Yes, certainly it helps. How soon after teriparatide do you repeat bone toner markers? It has been very clearly shown first month, third month, sixth month, and then at the end of 1 year. How do bone toner markers help decide between anabolic therapy and anti-therapy? We have decided, discussed that clearly. I'm not going to go back. How reliable are bone toner markers in thyroid and diabetes? No, it is not related, but certainly in CKD it is a limited value, so you'll have to keep it in guidelines. Which guidelines do you follow? The bone toner markers used in practice? Well, the International Osteoporosis Guidelines is the standard one. Follow that. Do you see bone toner markers standard of care in the near future? Yes, in the near future, if you have a regional standard value, you can use it, but don't use it for diagnosis. Use it only for follow-up therapy. Which type of osteoporosis management the most compared relied only on DEXA? So far, before the bone turner markers are available in India, we have been relying only on DEXA. So that becomes the gold standard. Don't repeat DEXA every 3 months. Repeat it not before 12 to 18 months. Yes, sir. Next.
that's all, sir.
Thank you.
So thank you very much for giving this one, sir. So in this series, next coming months also we'll have the.
It is very nice. I'll talk to you later. We want to more like this. We have to
Sure,
talk
sir.
about transition therapies, transitioning from anti-resorptive to anabolic, anabolic to anti-resorptive. They are very important.
Sure, sir.
Thank you.
So, thank you very much.
Thank you so much.